everyone, welcome back. We're doing another live Q&A session. Ella will be asking the questions that you guys are asking me, obviously, so she'll be reading off the questions. I'll do my best to answer them for you guys. Obviously, we love doing these. They help us, they help you guys as well. Slight tweak this week, we're gonna focus mostly on face this week. Periodically, we'll just do this because we have, obviously, most of our questions are body contouring, plus size tummy tuck related questions. And then so sometimes the facial questions get kind of lost in the melee. So we just kind of accrued some of our facial questions and then we'll go through them. But obviously we'll go through everything. So let's get going.
How has your approach to facial rejuvenation changed over the years?
That's an interesting question. How has my facial approach? Well, you know, I've always been focused on and preferred aesthetically more natural type of look. So I've never really liked it when I see, like for example, celebrities and they have very noticeable, like surgically imposed changes, you know, where you can see certain lines and contours and things of that nature. At least for me, that's not where my mind and my hands kind of want to go to. So I've always had that. I think maybe I've refined that a little bit more. I think one of the biggest things is I've realized that, and this has happened with almost all of my procedures, body, breast, is can I accomplish the same immediate result, the same long-term result or comparable with less intervention during surgery, you know, because obviously then it decreases risk, it decreases recovery time, bruising, swelling, discomfort. And so I think that's probably been the constant over the last 17 years of practice is how can I do things as safe as possible? How can I do things as best as possible? And then once you feel like you've kind of squeezed the most out of safety and results, then you start looking, well, how can I do this as efficiently as possible? Not from a time standpoint, but in terms of the least amount of intervention for the patient to get that result so they can recover quicker.
What's a lower blleroplasty and who's a good candidate for it?
Blleroplasty refers to the eyelids. So a lower blleroplasty just implies you're shaping the eyelid to a certain extent on the lower eyelid. Upper blleroplasty, obviously, it's the upper eyelid. Eyelid lift is kind of the common name for a blleroplasty because blleroplasty is the official medical word. Eyelid lift is the more utilitarian word, like saying abdominoplasty versus tummy tuck. But then just like abdominoplasty or tummy tuck, the proof is in the pudding of what that really is. So for example, a plus size tummy tuck is a fundamentally different procedure than, let's say, a regular tummy tuck, just from how I've developed and defined the plus size tummy tuck. So it's important to really define what it's doing and what it's not, what it's providing and what it's not. And it's the same thing with the eyelid lift or the blleroplasty. Because you can do a lot of different things and call it a blleroplasty. You can remove a little skin. You can remove a little bit of fat. You can remove a little skin, add fat. You can laser the skin and then add fat. You can do something with the skin, something with the fat, and then something with the lid ligament on the side. So as you can see, all those things are all part of blleroplasty. That just means you're changing the shape of the eyelid or shaping the eyelid. But at the end of the day, it's the surgeon's responsibility to define what the issue is that's causing the aesthetic concern for the patient, and then really figure out what the best solution for that aesthetic concern is. And of course, then you go right back into what I just mentioned, safety, service, and then efficiency. Meaning you want to make sure that it's the safest possible procedure for the patient. You want to make sure that's the best result for the patient. And then you want to create that result within that safety parameter that has the least amount of downtime for the patient.
This person said, I had a lower blef, bags came back. What is fat repositioning?
I'm going to sneeze.
Bless you.
Sorry about that. See, you can tell it's live because I'm sneezing. Well, so there's two things involved. On the one hand, yes, some of our fat cells do get bigger. And then when they trim fat, they're just trimming some of that fat. And then technically you can expand the residual of the fat that's there. Second thing is the fat is supported in its position within our bony orbit with a combination of ligaments and tissues. And as those ligaments and tissues stretch out, gravity kind of pulls that fat out. Third is there's a subcutaneous fat that's covering our orbital fat, the fat bags. And if our subcutaneous fat diminishes in size, it exposes the fat pads underneath it. It's like the tide goes out and you can see all the rocks in the ocean, right? And so those are three ways to have contour irregularity associated with fat in the lower eyelid. And so you have to define and diagnose that properly, and then you can treat it properly. Now, fat repositioning implies that you're taking some of those fat bags, you're taking that fat and you're, instead of having it a circular ball of fat here that kind of looks like a little fat bag, you're taking it, you're flattening it out, and you're repositioning it so that it creates a nice transition. You're basically taking too much of the fat that's here, and you're replacing some of the fat that has diminished down here. That's what fat repositioning is.
So this question is about the body. It says, in Sweden, they refuse to do a tummy tuck on a patient with a high BMI. Why are they so afraid?
Well, it's the same reason that a lot or most plastic surgeons here in the United States also refuse to do tummy tucks on patients that have a high BMI. And that's the same throughout the world. And all of that is based on the same ideas and the same data. And the idea in the data is that if you do a tummy tuck in a standard traditional way on someone that has, let's say, a BMI of 25, and then you do the same standard traditional tummy tuck on someone that has a BMI of, let's make it clear, like 65, for example, right? And you do that 100 patients of one category and 100 patients of the other category, you'll see that the patients with a BMI of 65 getting the standard traditional tummy tuck will have a higher complication rate. Usually wound healing issues. And the reason for that is those mechanisms on those tummy tucks are imparting some stress to the body. But the stress to the body for someone that has a BMI of 65 is going to be different than a stress to the body that's going to be someone that has a BMI of 25, because the patient with a BMI of 65 classically has a much thicker subcutaneous fat. And so the physiology and anatomy of that is different by nature. And so as people have noticed a higher complication rate with higher BMIs, usually starting at BMI of 35, then they stop doing tummy tucks on patients with a BMI of, let's say, 35. Some surgeons will accept 40, things of that nature. Well, you can stop there and just say, well, we're never going to do tummy tucks on people with a BMI of 35 or higher, or 40 and higher. Or you can say, well, maybe I can figure out a way to do a tummy tuck differently than a standard, basic, traditional tummy tuck. And that's basically what I've done over the last 17 years is I've modified the tummy tuck process, the abdominoplasty process, before, during, and after surgery with all of the different protocols. Our instructions to the patient, the way we treat the patients before, during, and after surgery, the way we do anesthesia, the way I do my surgery, all of our techniques and medications and all our technologies, all that has been modified incrementally over the last 17 years. And what we've have arrived at, slowly but surely, is a very high safety rate, both for healing, for high BMI patients, very high BMIs. Our highest BMI is 88, and also great results. So we've slowly tweaked all those things to be able to do a tummy tuck on a patient with very high BMI. Like I've said, highest BMI today is 88, and to heal perfectly without any issues consistently, and to have a great result. So the surgeons in other countries like Sweden or the UK or even in the US, they have not embarked on that journey. And because they have not embarked on that journey, your only tools that you have to do a tummy tuck is the traditional standard tummy tuck tools. But if you tweak those, if you adjust those, and you do so, and you embark on this long incremental improvement journey, because it takes a while to really understand how the body communicates to you and what it requires along the way. If you embark that and you spend enough time in that, you commit to that process, then you can do higher BMI safely. But that's the long answer to the question of why are high BMI tummy tucks not done generally.
Does age factor into the healing process?
The short answer is no. And the reason for that is age is just the chronological number of how long someone has been on the planet. But you can have someone that's 20 and be at a very high risk of surgical complications from anesthesia, but also from healing, all things given, all things being the same, compared to someone that has an age of, let's say, 65 or 75. And I've done surgery on a couple dozen patients in their 75 to 80 plus range, and they've all healed perfectly. And the reality is that if a 75-year-old comes to you in the office and they're healthy and they're still cognitively and physically active, they've probably lived a pretty good life, meaning they've taken care of themselves. They also have the genetic benefit on their side. They don't have a lot of bad genetic consequences. And so chances are those people are going to do just great during surgery. Now, the tissues have changed over the, tissues that are 75 years old are totally different than when they're 25 for the most part. So the surgeon has to treat those tissues specifically given their capabilities. Just like I need to do a tummy tuck differently for someone that has a BMI of 75. I need to do surgery differently than someone that has an age of 75 than if someone that has an age of 25. So it's incumbent on the surgeon to understand all these specific differences and then adapt to them. You can't cookie cutter your way through great surgery.
Can you do a tummy tuck if the person has a lot of scar tissue?
Yes. And now the scar tissue could be within the skin, or can be within the fat, or could be between the fat and then the fascia, which is the connective tissue on the muscle. Scar within the skin, if you have enough skin there, you can just excise that, right? Because that's what a tummy tuck is, excision of some amount of skin, of scar and skin. Now, if you don't have enough loose skin, then that becomes a different issue because then you have to expand that skin, tissue expanders, things of that nature. Separate discussion. If there's scar within the fat, then it's the same idea. You can excise that. If there's scar between the fat and the fascia, then you can dissect on top of it and peel it off and remove it.
What would you say are the biggest no-nos after surgery?
Well, since surgery is so different types of procedures, since patients are different BMIs, different health standards, different things of that nature, and since surgeons are so different, then the biggest no-no is going to depend on all those parameters. I think if I was to distill my experience over the last 17 years to the biggest no-no in general is respect the process, right? So, meaning you're going to spend money having surgery. There is something about your body that you don't like, or your face, and you want to improve that. So you're going to go through this leap of faith of having surgery. You're going to research your surgeons and choose a surgeon. But at the end, you're still doing a leap of faith. I hope this surgeon does a great job so I can get a great result safely and effectively. And you're investing time and money into that process. I think the biggest no-no is to then say, well, I'm also going to not change the way I live my life in the first couple of weeks of my life. So I'm going to continue to work and try to run around and not invest in my recovery. I think that's the biggest no-no is your body needs time to recover. It needs you to follow the protocols of recovery as best as you can so it can recover as fast as it can. And so sometimes I see patients trying to do two things at the same time. They want great healing, they want fast healing, but they also want to still clean the house, go to work, run the errands, get in the car, drive around, not wear their garments, compression garments, not sleep in a certain position, not do the things that we tell them to do with regards to facial rejuvenation surgery. And I think the biggest no-no there is I think you're trying to do two mutually exclusive things. At least for a couple of weeks, just hit the big reset button and say, listen, I'm investing time, energy, money, my faith into this process. I'm just going to do all in on the perfect recovery. I think that's the biggest component, is just really hitting that pause button for at least a couple weeks.
Do you usually keep the belly button or create a new one?
I usually keep the belly button unless the belly button has issues. Now, there are people who with massive umbilical hernias where the belly button is really only alive because it's connection to the abdominal skin. So once you make that incision around the belly button to do the tummy tuck, there is no blood supply there, and then keeping it is not going to survive. So in that case, I'll recreate a belly button. Some patients, their belly button is so scarred in that, again, you may want to recreate a belly button. But if the belly button is not problematic with blood supply or scar tissue or other issues, then I usually keep the belly button and use it to have the new belly button opening.
Why can't we freeze fat to sell or reuse like in a BBL transfer?
Well, there are companies that will now started offering the ability to store your own fat. And it's your choice as a patient whether you want to do that or whether you want to just use that fat when you have it and then later on figure out whether you want more fat harvested. Because the philosophical question is, if you're taking that fat, it right now has blood supply and it has physiology and it has a certain metabolic interaction with your body and it has a certain body temperature and warmth and sterility, all that stuff. And if you're taking it and you're putting it in a bag and you stick it in a refrigerator, it doesn't have that. So that's a different environment. So the question now is, are you willing to take the risk of that fat being the same viability or potentially contamination or potentially other complications? Or are you just are you better off by just storing the fat in your body? And that's a philosophical question. And it's also deciding what's best for you, because you're going to have to pay to have that fat stored as opposed to just storing it in your own body and using it when you need it. As you can tell from my wording, I'm a bigger fan of keeping things natural. I like working with nature as opposed to against nature. I like keeping things as simple as possible as opposed to increasing complexity. And so one of the reasons for my success, be it as it may, however you want to define that, from a surgical standpoint, is always looking to have maximum safety, maximum results, and minimum complexity. Because complexity muddies the water and it can, I'm going to use a big word, obfuscate the things that the body is telling you that you need to pay attention to. And if you have a lot of complexity, and you can miss those little cues. So back to the fat harvesting and fat storage, is you're going to have to make that decision for yourself. There are services that are being provided now. I'm not a big fan of those. Now, in terms of selling your fat, that's a whole different market, because it's, first of all, illegal for you to do that. There's rules in place for that for a lot of different reasons. Second, the person that will be buying your fat, if that was legal, their body would reject that fat, because their body would recognize your fat that you have sold them as foreign. So you can't sell the fat. You can store it for your own use, but the question is that the best thing for it? Obfuscate, that's the word.
Do you do surgery on people who have had a gastric sleeve?
A ton of our patients have had bariatric surgery of some sort. Bariatric surgery is surgery that impacts certain changes to the GI tract to lend that body to lose weight through a lot of different mechanisms. So there's gastric sleeve, there's gastric band, there's gastric bypass. Those are the three main ones. And a lot of our patients have had one of those surgeries in the past, and that's not an issue.
Do you recommend getting to your goal weight prior to surgery?
I don't have a preference. I don't have a weight or a BMI restriction. Now, the only caveat to that is if a lot of your weight is intra-abdominal, I can't do anything about intra-abdominal fat, so it'll be helpful and important for you to work on that. But you can work on that before, during, and after, for example, a plus-size tummy tuck to get the results that you're trying to achieve. Decreasing intra-abdominal fat after you've had your surgery will not negatively impact your surgical results. Your skin will adapt to that decrease in volume. So it's up to you. I mean, the thing that I've learned along the years is I've done surgery on patients who are obviously big, because we do big patients, BMI of 65, 75, 88. And the impact that it's had on some of our patients has been profound. Physical impact, mental impact, emotional impact, things of that nature. And that really results in basically fast forwarding a lot of great benefits, physiologically, mentally, physically, changes in their lifestyle patterns. And had those patients waited 5 years to lose more weight, they would have lost on 5 years of the changes that they've instituted as a result of having surgery. So I think it's everyone's personal decision, but I don't have a weight or a BMI restriction.
Will surgery interfere with an autoimmune disease?
It will not. We've done lots of patients with various types of autoimmune disease, and it does not. I could imagine situations where you do certain big body contouring procedures where it changes then some of the physiologic parameters, and then also results in the patients doing certain changes in their life that then improves some of the autoimmune diseases, at least the symptoms.
Can I sit down after a BBL?
Yeah, so if you think about it, right now I'm sitting down and my fat cells in my buttock area are just fine. So there's no reason why I can't put fat in, for example, your buttock area, and then you can sit on it. Now, the reality is that sitting is not a natural position. We've created chairs and sitting, but we're not really designed to sit. We're designed to squat, we're designed to lay down, we're designed to walk. So afterwards, you really should be in a recumbent position, kind of a beach chair position, where you're dispersing the weight of your body throughout your whole body, back, butt, legs, things of that nature, as opposed to putting all of your weight on, let's say, just your buttock area if you're sitting. Then, of course, you want to have lots of good, nice padding, because why would you have surgery and then squish it on something that's very firm, a wooden bench, for example. So yes, you can sit on it, but I would minimize that, and I would definitely use lots of padding. But you should really be standing, walking, or laying in a recumbent position.
What do you use for pain management after surgery?
Well, we do prescribe narcotics to patients to use, but vast majority of our patients end up not using the narcotics, and if they do, they just use it for the first day. Most of our patients just take over-the-counter medications, even for big body contouring procedures. And I actually realized this maybe about 3-4 years ago when I did a 10-hour surgery on a patient from out of state. And then I went to go see the patient in our overnight facility. And the patient's like, I have zero pain. I mean, I have, some discomfort, but I have literally zero pain. And obviously it's not like nothing ever happened. They felt the surgery, but they were doing just fine. And so that patient just ended up just taking some over-the-counter anti-inflammatories for their discomfort. And so I reviewed how I did my surgery, I reviewed how we did our anesthesia, and I reviewed how we did some of our intraoperative processes and procedures. And then I started expanding on those. And since then, the vast majority of our patients haven't really needed to take narcotics. Maybe about 90% of our patients have not taken the narcotics. But we do prescribe narcotics. We do a bunch of stuff intraoperatively with numbing medications and with anesthesia. And that seems to be helping.
What can disqualify you from getting surgery?
Safety. You never want to do surgery taking on unnecessary safety risks. So let's say your heart and lungs are not in good shape. Your ejection fraction of your heart, your pulmonary function percentage is very low. Well, going into surgery for elective surgery is an unnecessary risk. We want the heart and lungs to be reasonably safety able to undergo anesthesia. And so that's the thing that will disqualify a patient. I guess the other potential disqualification is, but it's not really a disqualification, it's a barrier to proceeding. It's someone who wants a certain result that I cannot accomplish. And so an example of that is when people just have generalized poor skin quality in areas where I can't really aesthetically contour. And the examples of that is like, loose crepey skin on the elbow or the knees, just generalized cellulite that I can't really do anything about, because those patients, obviously the skin has lost its elasticity and there's just no great way I can change the quality of the skin. I could tighten it by putting incisions, but the incisions will always be there, and nobody wants incisions on the knee and the elbow and things of that nature. So I guess the other hindrance to going forward with surgery is if I cannot reasonably provide a solution for surgery that is reasonable for the patient to take on, the amount of time and money invested in that surgery and the placement of the incisions and the quality of the results just don't match up.
Can you explain why you don't have a price list on your website?
Because the price of our quotes are all time-based. So, we talked about during this live Q&A on the patient that has a BMI of 25 and the patient has a BMI of like 65. As you can imagine, the length of the incisions, the amount of liposuction, the amount of time in the operating room are different between those two patients, and therefore a tummy tuck for the patient with a BMI of 25 and a tummy tuck for the BMI of 65 is going to be different. The time's going to be different, the cost is going to be different. So we can't really put a price on the website. We can do very generalized ranges, take into account, like, let's say approximate cost for someone with a BMI of 25 and approximate cost of someone with a BMI of like 65, and do a price range for a BMI for a tummy tuck. But the price ranges are very broad, which is fine, but it becomes, at some point, it becomes not helpful, because then if somebody looks at that range and they're being a foot taller and a BMI of 75 with a previous scar and a couple hernias, that time is a little bit higher still. They might even go beyond that range. And conversely, someone might be super small and their price range might be even below that amount. So we can provide price ranges, but they're going to be very generalized, because ultimately everyone's cost is specific on the amount of time needed to do their specific surgery and get their specific result.
Okay, last question. How do I get a consultation with you?
Yeah, sounds great. Yeah, so lots of different ways. So we're on Instagram currently. You can message us here on Instagram. Ella will answer that for you. They can help you getting a consultation. Ella or Evelyn or Colleen or Brittany or Amber, they can always help you with getting that. You can also call us. Our phone number is 855-377-3782. We have two websites. We have drrepta.com and plussizetummytuck.com. They have a little consultation at the button. You can click on there. We do both in-person and virtual consultation. Your choice which one you get. Obviously, half of our patients are out of state or out of the country, so they tend to go with a virtual consult, but you're welcome to do either or both. As a general rule, we tend to book out 2 weeks out for consults and about 2 months out for surgery. That increases and decreases periodically based on a variety of different factors, but those are all great ways to get a hold of us.
Thank you.
All right, guys. Till next time. Great job, everyone.